Good evening, everyone. Today, Dr. Anushka Rani, and on behalf of Voice of Healthcare, I welcome you all. Third edition of National Hemophilia Forum 2024. The topic for the discussion is equitable access for all. Organized by VOH, this thought leadership discussion, we are happy to have an esteemed panelist today, Dr. Manisha Madkaikar, Scientist G and Director of ICMR, National Institute of Immunohematology, and ICMR-Center for Research, Management and Care of Hemoglobinopathies, Dr. Tulika, Seth, Professor of Hematology at All India Institute of Medical Sciences, New Delhi, Dr. Suresh, Professor of Pathology at JJM Medical College, Davangere, President, Karnataka Hemophilia Society, Dr. Rahul Bhargav, Principal Director, Hemato-Oncology, Fortis Gurgaon in Noida, and Dr. Ramnath Nevrekar, Goa Medical College, Unit Head for Hemophilia. I welcome you all. Moving forward, I request Dr. Tulika Seth to kindly set the stage by addressing our first question. Ma'am, what are the current challenges in diagnosing hemophilia in India, and how can we overcome them to ensure that there is an early detection and intervention for hemophilia?
So I think the most important thing is awareness. If the doctors are aware and they order the test, the basic test of a PTT is very simple and it's available in hospitals. Having a good coagulation lab is again a very important thing that most hospitals should think about. If you have a good coagulation lab, then not only can you diagnose hemophilia, but patients with other bleeding problems like trauma patients, patients with liver disease, postpartum hemorrhage, snake bites, all of these things can also be identified. So basic tests can actually be used to identify patients with hemophilia. Obviously, identifying the severity and identifying inhibitors and other things requires a more advanced laboratory and better training. But basic diagnosis can be done with good awareness and a basic lab.
Thank you so much, ma'am. Ma'am, having said that, what is the current status of the availability of coagulation labs in India, and how is it in tier 2 and tier 3 cities?
So in most of the metros, there's really no problem. You can even diagnose rare bleeding disorders. The tier 2, tier 3 cities, if you have a medical college or a good private hospital, most of them will be having availability. The government of India has also done a lot of very good initiatives. There are integrated centers of hemophilia and hemoglobinopathies in more than 100 district hospitals. So there is definitely progress, but obviously more needs to be done. And as I said, we need to start out with awareness, because if you know that this is important, you will ensure that these tests are available and you have the training and the required equipment.
Thank you so much, ma'am, for shedding light on the intervention part. And since you've also reflected on the accessibility issues and status currently in India, my next question is to Dr. Suresh. So, in one of your posts that I read, there was written that hemophilia is a lifelong genetic bleeding disorder, but physical disability can be prevented with proper and timely treatment of internal bleeding episodes. For the internal bleeding episodes, sir, how accessible are treatment options for hemophilia patients across different regions in India? And what initiatives are being taken to improve accessibility for the same?
Mainstay in the management of hemophilia. The deficient clotting protein has to be replaced at every instance of bleeding. But we have learned a lot of lessons in this direction. So initially, because of the non-availability of the specific factor concentrates, our patients were treated by these wet blood products, exposing them to the risk of bloodborne infections. But with the growing technology, the viral inactivation methods have been introduced, and that's how it has come down. And with the recombinant technology, and further the development in the technology, having extended half-life factors, and nowadays even the non-factor therapy, long-acting therapy. So these are all the available and developed methods in the treatment. But the initially, because the episodic treatment was the predominant method of treatment in India when factors were made available. But we have realized that even episodic treatment is not ideal to prevent disabilities among hemophilics completely. Hence, we need to advocate for prophylactic replacement of these factors so that the disabilities can be prevented, our children can go to school, get good education, and lead quality health. So this is how the factor concentrates thing. And yeah, as far as the accessibility is concerned, as far the accessibility is concerned, the still there is a long way to go. Especially the medicines are now available most of the district hospitals and bigger hospitals, but this has to go like a, especially when we start using prophylactic replacement of factor concentrates. I can give a good model of successful therapy. For example, anti-tubercular drug therapy, and how it was distributed all over the country, all over the different districts and taluka places. So one is the availability of the quality products. Number two, making the accessibility using our own learned lessons like this anti-tubercular drugs distribution system and logistics, and all these things have to be included. In addition to this, we need to empower the nurses. We need to, because nurse must be empowered, because most of the doctors they are all busy, and it is wiser to empower our nurses for coordination. For coordination, all these accessibility issues can be sorted out. Availability of the quality products definitely makes the life of hemophilics good, with good quality life.
The two dimensions of accessibility, which is affordability, and of course the availability of the treatment. There is also a third side to accessibility, which is patients being aware and approaching the healthcare setups to access care. So how can we ensure that patients and caregivers are empowered with that knowledge of awareness that yes, this is the time that they need to approach a healthcare setup, and not only during emergencies.
That's what our system has to be empowered. It is not just the medical fraternity, our patient self-help groups and organization chapters of Hemophilia Federation. All of us together can plan to create, to empower the patient's family with the knowledge of hemophilia, availability of the factor concentrates, and even the complications associated with it. Everything we need to empower the families. And also we have 500 plus medical colleges, and we need to empower or promote the comprehensive concept of hemophilia care, which is very successful in the Western world. So that's why there are so many medical colleges, but comprehensive care model still it has not come into all the medical colleges. I think a comprehensive care concept promotion with government or private medical colleges has to be taken very seriously.
Sure, sir. Thank you so much, sir. Moving forward, my question is to Dr. Ramnath. Sir, can you please shed light upon the ground reality of hemophilic patients in Goa right now? and how do they effectively manage on a day-to-day basis? What are the knowledge and resources they are currently, they can access?
Yeah, so in Goa, we are a small state. We have around approximately 51 patients of hemophilia and associated bleeding sort of disorders. So we have a society, Hemophilia Society, which is doing an active, playing an active role in creating an awareness amongst the patients. All the new patients get registered at this society. There are two societies at the moment in Goa, and they are doing a fairly good job in terms of creating awareness. And also, because the number is small, they always give a personal sort of attention to this patient whenever they are in the need of, suppose they have an acute hemarthrosis, then if they so now we have started a comprehensive hemophilia daycare center where we have kept a ward. There are a few beds kept reserved exclusively for hemophilia, both the adult wards in the medicine wards and as well as in the pediatric wards. Dedicated beds, only those patients are kept, and all factors are available free. We have made sure that we even have the extended half-life factors available. And recently, we have also started giving the prophylactic factor therapy, which I believe is the order of the day. No patient should have even a single bleed, and our vision should be that all patients of hemophilia should live a life without disability and with a proper functional sort of capacity. And I'm also happy to share you that the Goa government has providing even the newer molecules like emicizumab, which is useful in prophylaxis of hemophilia A. This emicizumab has also been provided free of cost, and we are using it for this Department of Physiotherapy. And we have made sure that all these patients who get factors are given also physiotherapy, and that's how they are made functionally, more active. So the society is doing a fairly good job. Plus, we conduct awareness program, training programs for physicians also, because a large lacune here is even physicians, general physicians, or even physicians in the district hospital. They do not have proper knowledge about management of factors, and also prophylaxis is not looked upon seriously. Most of the time, comes with bleed, and they are given factors, and then you treat them and you send them. But that should not be the order of the in the current. We have to.
So we're losing your audio in between.
Am I audible now?
Yes, so you're audible now. We had most of it, but just the last. Again, you're on mute right now. So kindly unmute yourself.
Am I audible now?
Yes, sir, you're audible now.
Yeah. So the Directorate of Health Services has a network of all district hospitals and CHCs, community health centers, where all the doctors therein are getting trained periodically for the management of hemophilia.
Thank you so much, sir. Having discussed, it was good to know that Goa has the accessibility in Goa is pretty good, and government is taking a lot of initiatives. And because of the small number, we are being able to reach out to hemophilic patients. It's really good to know that. Moving forward, my next question is to Dr. Rahul. Sir,
Yeah.
So we've heard about the coagulation labs, we've heard about the management protocols that are in place, and we've also heard a kind of a case study from Goa's side. But North India India in general is very diverse, and North has very large number of states, and the population size is also again. So what is the role that public-private partnerships can play in advancing diagnosis and treatment and support services for hemophilia patients in general in India? And if you can share your insights for North India as well in specific.
So, first of all, I would say we should stop dividing the country into public and private, or the corporate versus the government hospitals. We should see health as a one nation, one criteria kind of a vision, where we say how each individual who has been trained in this country can be utilized his knowledge to get and serve the best to the people of the country of India who has born on this very, very pious nation. And not only this, we also have a responsibility for across the nations once we have fulfilled our own responsibility of serving our own people. So I've been in a completely a corporate hospital with a, I would say, outside looking like a corporate hospital, but inside is a socialist heart and a mind, where we conduct our OPDs not only in Fortis, but across Gorakhpur, Indore, Bareilly, Patna, right now sitting in Lucknow, okay, and going as far as Bikaner. So the whole idea is the dissemination of knowledge, how it can happen. How we can ever expect that AIIMS being loaded with 250 patients every week, each week by week for 365 days a year, 52 weeks, to see hemophilia and serve them. It is not AIIMS which has failed, it is the states which has to upgrade their services so that the quality of healthcare and research can happen in these institutes. They are not only meant to give factors, they are able to make guidelines for the country. First of all, that is very, very important. And that is why I always keep on talking about the innovation versus the implementable knowledge. I am in the process of not innovation. I might innovate someday from a corporate hospital, that's a great thing. But right now, my primary duty is the implementing knowledge, what I have learned through All India Institute of Medical Sciences and various federations, and take it to the last mile. Whether be in corporate or in public, we have to serve the patients in their own setup. We cannot expect patients to be following the guidelines. We cannot expect patients to be aware of each and everything of 120 disorders which we have to talk about. Voice of Health is talking about tuberculosis one day, talking about multiple sclerosis, spinal muscle atrophy. So if some common person has to keep on listening to this, probably in a year they will have 150 diseases they have to learn through. That's not their job. It is us who has to disseminate this knowledge, establish the implementation. So through our networks, we have been able to establish in Gorakhpur. We have been able to establish bone marrow transplants in ESI Faridabad. We expect that we will find one day doctor who will join ESI Faridabad and then the whole process will start. No. Let all the public and private sector people come out of their comfort. Every month they should adopt one district and try to develop this Goa model. So these smaller units will become the larger chunk for giving and establishing the state of the art. We don't have the dearth of money today. What we have is the dearth of knowledge, commitment, and sharing good practices with the rest of the country people. So it is imperative that communities has to join hands. This division between communities, between private and government has to break away. We have to move from a model where it is a unified people. So I urge all my hematology friends to adopt one district to eradicate not only hemophilia, but anemia. So we are talking only of hemophilia treatment today. But country like us who has got 2.5% of GDP being spent on the healthcare, where we have got diabetes, hypertension, tuberculosis, geriatric population growing in nature, do you think that we'll be able to serve all these bypassing agents and hemophilia factors for lifelong? What the government has done is a fantastic job, not being still a welfare state like UK. You have to understand the population of US is 35 crores. We are 3 times the population of US and 1/3 the space. So you have to also understand the Can you hear me?
Yes, sir,
Yeah,
we are
now we
audible.
can.
Can go on.
Yes, sir, you can continue. I think we've had a deep insight about responsibility and ownership and bringing hemophilia and addressing the issue under one umbrella from Dr. Rahul. I think he'll be rejoining us soon. But moving ahead, my next question is to Dr. Tulika. Ma'am, based upon what Dr. Rahul just said and shared about, innovation part and how bringing innovation to the last mile, are there any promising researches or clinical trials happening in India that could potentially revolutionize hemophilia treatment care in India?
It's a really exciting time, and just like we are seeing a lot of innovation in same has been happening in hemophilia. As was said by the earlier speaker, we had a lot of issues and only blood products were there. Now we have recombinant factors, we have life factors, which means that fewer injections need to be used. We have non-fat products, which again be given subcutaneously, so that's very useful for pediatric patients, intravenous injections. There are therapy trials that are going on which are curative. In India already gene therapy trials are there, and we are so it's actually a fantastic to be in the field of hemophilia because many can think that
I think we're having some technical issues from Dr. Tulika's side. Dr. Rahul, would you like to continue, sir? So kindly unmute yourself.
Okay. So I was telling that the private sector, which serves the 80% of people, has got a huge role. We all has to move out of the comfort to go and serve the poor people. People who are listening to me will not feel pretty happy. We say it's a cartelization of things which has happened. We have kept the doctors in the private sector serving only 80% of the richest and the rich people, leaving those 80% of the poor to the government to be served, and overburdened doctor. My colleague, Dr. Tulika said, and all my colleagues who work in a government hospital, I've got all the sympathies, because the amount of work which they have to put in to serve the people, those 80% poor people with limited understanding of life, is huge. So it is our responsibility that we cannot shun away saying, I work in AC chambers and I will not go into the muddy pool to serve the poor of the poorest. Because hemophilia is not the problem of magnolias or aralias of the neo-rich. It is the problem of the poor. So we have to go where the disease demands to serve us, and let's not wait for the people to move to the corporate hospitals to get it served. So that is why my view. So I might be wearing a corporate shoe today, but the heart still remains socialist and communist, and believing in a mind that all the people, irrespective of their caste, creed, sex, and religion, deserves the best treatment which the government of India is trying to provide.
Thank you so much, sir, for your insight. Dr. Tulika, would you like to continue, ma'am? Ma'am, kindly unmute yourself. I think we're having some technical issues again. So moving forward, Dr. Suresh, sir, in what ways can healthcare professionals and advocacy groups collaborate to raise awareness about hemophilia and other bleeding disorders in India? And how can we penetrate into the regional areas and not just the metropolitans? So kindly unmute yourself.
Yeah, audible now?
Yes.
Yeah, actually, to further improve the care, actually advocacy is very, very crucial. But advocacy can be effectively taken care by the patient self-help groups. Our Hemophilia Federation, all the chapters, 90 plus chapters, So in their own region, in their own capacity, they need to advocate with the policy makers about the importance of prevention of disability, about bringing up the prophylaxis as a main treatment modality, and also the improvement in the psychosocial aspects, especially the prevention of hemophilia by setting up or promoting the genetic laboratories, especially in metropolitan or at least some regional wise. And we need to, it is not just setting up the diagnostic modalities, and also we need to establish the centers for genetic counseling. The mothers, wives, so then the sisters, all these people have to be counseled for proper carrier detection and further prenatal diagnosis, thereby preventing these expensive children, which reduces the healthcare burden also. That is one. Then, but this, as I told you, advocacy can be launched by the self-help group or patient groups effectively. Then the second part is the improvement in the quality of life. Improvement in the quality of life. Yeah, the collaborative approach. So as I told you, there are 500 plus medical colleges in India, but hardly few of them uh, have comprehensive modality of treatment. But comprehensive care is the key for success of hemophilia care. So these points also we need to keep in mind and try to advocate with the policymakers to implement, to inculcate comprehensive care modality.
Thank you so much, sir. Yes, Dr. Rahul. So
So
can you,
just
yes,
keeping
sir.
that in mind, we have just started at Fortis the genetic clinic, and we have hired a geneticist from AIIMS, and that's two things which has happened very nicely in this country. That AIIMS and SDPGI was a champion of producing the geneticists, which we don't know much about it. We have heard and read about genes, okay? But the way we live and breathe hematology, similarly, the geneticist now knows about hemophilia and the genes which causes it. So that is how the use of genetic counselors pre marriage, or we have what we have started in Gurgaon in North India is during the marriage and festive seasons, we have called upon all the journalists to start writing it one unison and one synchrony to create an awareness about thalassemia and hemophilia. So a premarital kind of a checkup can be utilized for these genes to be seen so that the penetration into the various communities can be dealt with. And in finite time, by say 2030 or 2035, we should aspire to make country from free from any newborn hemophilics until unless the spontaneous mutation, which is very rare to happen. But this inheritance will start coming down. So we need to have a policy advocacy the way we have done for factors, the bypassing agent. Now the time has come to ask for more steeper targets for us, which is of making any new born baby mandatory, which is government of India should know where the hotspots are, and then making a community level changes to prevent hemophilia babies from being born. I think that's the way the future of the country will become better, because we still continue to spend money on thalassemia and hemophilia out of 2.5% of our GDP, which is still we cannot afford because we are a developing country. So that is also what Dr. Suresh has talked about, the advocacy at the policy level and changes into our mind that through Janam Patri to genetic Patri, this journey has to be traveled.
Thank you so much, Dr. Rahul, for such an effective message there. I'll go back to Dr. Tulika. Ma'am, we lost you due to technical issues. I'll repeat my question, ma'am. Ma'am, are there any promising research or clinical trials happening in India that could potentially revolutionize hemophilia treatment and care? I'll also add one more dimension to this, ma'am. Ma'am, currently, do we have all treatment options in terms of technology or testing in India? or do we need to collaborate? Is there a scope of collaboration with an international organization? Any sort of learning from them to incorporate to help hemophilic patients in India?
So, absolutely, there are a lot of scopes for international collaborations. But I also think there's a lot of innovation happening in India itself, both in the diagnostic as well as in the therapeutic area. For the diagnostics, the ICMR NIIH has made point of care kits, which will allow the diagnosis of hemophilia and von Willebrand disease, even in remote areas. So that is an innovation that has been done in India. In the therapeutics, we have gene therapy, which has been an innovation in India. And also, there is a scope of collaboration with international organizations for gene therapy. And at AIIMS New Delhi, we are hoping to be doing a collaboration internationally for gene therapy for both hemophilia A and hopefully for hemophilia B as well. So there is definitely a lot of scope. And as I said, there's a variety of products which are now available to us in India. We even have the non-factor products, and more new non-factor products are going to be coming up. The advantage of the non-factor products is, one, it is subcutaneous, so it's easier to administer. It can be given like an insulin injection. You don't need to have an intravenous injection.
Ma'am, you're not audible. Dr. Tulika, you're not audible. Um, I think we've lost Dr. Tulika's audio due to some technical issues. I request Dr. Suresh to kindly reflect upon how gene therapy and non-factor products, like Dr. Tulika just mentioned, are helping reduce the patient load and help improving our patient management in patients, hemophilic patients.
The international collaborations are in the form of having clinical trials. The gene therapy trials are going on, but still there is no much, the uh, positive outcome, and it is limited to only very bigger institute. But still, I think we need to be optimistic that gene therapy will come, and it is successful in factor 9 and all those things are aware. But we still, I think we may have to wait for some more time.
Thank you, sir. Dr. Tulika, are you able to? We could not hear you earlier.
Sorry. Yeah.
Sorry, ma'am, we lost you at when you were discussing about the non-factor products being administered subcutaneously. We lost you there, so you may continue from there.
Okay. So as I said, the non-factor products can be used in patients who have inhibitors as well as those without inhibitors. The non-factor products can be given subcutaneously, and they can be given after a very long period of gap. So there's many advantages to these because you have fewer injections and the quality of life of patients is vastly improved. So we already have one approved non-factor inhibitor, which is approved for hemophilia A. And hopefully there'll be several newer non-factor inhibitors, which can be used both for hemophilia A and hemophilia B patients. And as I said, these can be used in patients who have inhibitors and also in those without inhibitors. And the other exciting field is patients who have acquired hemophilia. So often people feel that, why should we be bothered about hemophilia? It's a rare genetic disorder. Well, even normal people can develop acquired hemophilia. And this is a disease that can happen in women around the time of pregnancy, in many people who have autoimmune diseases or people who have cancer. this is a very serious life-threatening condition. But again, the products used for hemophilia can be very, very effective, and hematologists can treat this life-threatening condition. The acquired hemophilia is not a permanent condition; it can be treated. Whereas the inherited hemophilia that we are talking about today is obviously a permanent situation. But a lot of lessons learned from the inherited hemophilia can be applied even for the acquired hemophilia.
Thank you so much, ma'am, for sharing insights about acquired hemophilia as well, and also quality of life in patients, irrespective of the therapies that are available. Dr. Suresh, would you like to say
Yeah.
add some?
Yeah, here I would like to, because today is World Hemophilia Day, and as per the theme, no, we also need to raise awareness about recognizing other inherited bleeding disorders, especially the Van Willebrand disease among women, which is most of the time we miss the diagnosis, or there is at least 5% of puberty menorrhagia, they have Van Willebrand's disease. But many people are not aware, and especially the OBG specialists. So we need to raise awareness about inherited bleeding disorders among women, especially Van Willebrand disease, and its diagnosis, its identification, everything we need to. And also the other rare bleeding disorders, for example, the factor 13 deficiency, where the woman will have repeated pregnancy loss, and the prolonged bleeding during the birth, that is separation of the umbilical stump. So all these things we need to consider, along with all together, all inherited bleeding disorder, creating an access for healthcare facilities. And since today is World Hemophilia Day, and theme is the equitable access for all inherited bleeding disorder, I thought I should raise this point. Thank you.
Thank you so much, sir, for raising this relevant and emphasizing on the theme of, the Hemophilia Day today. Thank you so much. Moving forward, based upon what Dr. Tulika has mentioned in the discussion today, my next question is to Dr. Ramnath. Sir, you briefly mentioned how successful the initiatives have been in Goa and they've shown a positive result. But how do we address the socioeconomic factors that often hinder the access to comprehensive care? And also, what about the quality of life in patients who have been diagnosed, and we are providing them with good care as well? But how does the quality of life? What is the status of quality of life in those patients? So kindly unmute yourself.
So first of all, since Goa is a small state and we have a limited number, it is quite possible. But for larger states like Maharashtra, Karnataka, it's always a challenge, which always I agree. But at least I feel that each medical college or a district hospital, the least minimum that we can ensure that at least the district hospitals and if not medical college, they should have a small facility, dedicated facility, where these hemophilia patients can at least, once they get bleeding, they can come take factors and at least get the first point of care treatment. Because the more you delay the factors, the more the bleeding will be. So recently we and the and we had a maternity and child care hospital where those doctors was a hemophilia patients around 80. There is no medical locality. So normally they used to take treatment. That would be a time delay 6 to 7 hours before they reach Goa. And by the time the bleeding would have increased. So what we thought, like in collaboration with the Hemophilia Society of particular uh, to them and all this uh, around facilities for them.
So we're losing your audio.
Am I audible now?
Yes, sir, you're audible now.
Socioeconomic factors are definitely a challenge, but as we know that factors, simple, at least the factors are free for the patients as per the rules of the government. And so at least each and every medical college in the state and district hospital, they should have a dedicated facility, which will go a long way in addressing their concern of treatment. Quality of life better only when they receive treatment in time and stability. Uh, this second, let's see
So we're losing your audio again. It's better now, sir.
No, we have to make sure that the patients who are bleeding frequently, they should be given prophylaxis at least once a week, if not twice a week, at any closest place where they can come take the factors and go. In fact, we have come with another innovation is some patients who are well educated, they have been trained for self administration of factors at home. And 2 or 3 of our patients who are very young and who are educated are taking these factors at home. So what we do is we give them the bottles, the vials of factor to be kept, and so that they can utilize them for self administration, and they have to return the vials after that. So what happens? Cuts down their time required to reach the hospital.
Thank you. So we lost your audio right now. So we heard about the self-administration part. You may continue from there.
Yes, so self-administration of factors, particularly for the ones with frequent bleeders and who are adult patients, or even mostly the adult patients who can take the factors by themselves. It's a boon for them. In many Western countries, even children in school and colleges who have hemophilia are trained to take these factors, because everybody, even in other cities, major metropolitan cities, there is always a time delay to reach the hospital. So if some of them can be trained in this manner, they can cut down their time, access to the receiving this factor can be cut short.
Thank you so much, sir.
Also, we have to make sure that they receive timely physiotherapy, exercises, periodic checkups, and there is also the correction of deformities can be done by orthopedicians by giving them factors and taking them for some surgery. Although this facility is not so much present in Goa, but we are soon in the process of upgrading our facilities here.
Thank you, sir. Moving forward, I'd like to say...
Hello?
Yes, sir. So would you like to continue with... Yes,
I would just like to say that like we have other healthcare programs for many other disorders, but there is no national program. So if the government can at least have some sort of initiative, I know that it will be a huge cost and all that, but then somewhere there has to be a starting point that at least in a limited manner, if not prophylaxis, at least the treatment should be there in each and every medical college. If there is some policy by the government like that, and there is a national program like that, then I think that would go a long way in
Thank you so much, sir. Yes, sir. Definitely having a national program for rare disorders is going to be extremely beneficial in spreading awareness and managing such diseases. Before we wrap up this session today, I have a few questions from the audience. The first one being to Dr. Suresh. Sir, during the session, we've mentioned that some hemophilia patients, if they don't receive timely treatments, they might have to they might suffer disabilities. So could you please elaborate on that? What kind of disabilities and how does the quality of life change and how do they manage their lives post such disabilities? And are these disabilities permanent or they can be, they're not so permanent? So kindly unmute yourself.
So what I was emphasizing on the prophylaxis is the only way we can prevent disabilities. Even episodic treatment also may not prevent disability, but to some extent it can prevent joint damage. And with physiotherapy and orthopedic intervention, we can improve the uh, quality of life. But good quality of life, even as per the World Federation of Hemophilia, prophylaxis is the gold standard treatment in hemophilia, which has to be emphasized, which has to be implemented in our country also, because it has got a multifaceted advantage. Because right now, because of lack of prophylaxis, our children gets repeated bleeding, they cannot go to school, and by the time they enter into adolescent age group, they uh, they become innocent victims for disability, painful disability, which certainly affect the quality of life. Most important is education. If there is no proper education, our patients cannot take up hard works. They have to be placed in a good jobs, stable jobs. So for this, the education is crucial. That is one aspect. Then the second one, the it depends upon the type of bleed, the disability. Whether there are some disabilities where it becomes permanent. For example, bleeding in the flexor group of the hand can deform the joint, ischemic contracture of the hand, and foot drop can occur. So yeah, even iliopsoas muscle bleed. So these are a very bad bleed which can lead to permanent disability. So at least as Dr. Ramnath was mentioning, so at least at the earliest sign of bleed, factor should be taken by training our youths in, or even mothers or families, of self infusion. Because what is happening, factor is available in government hospital, but when they bleed in the midnight, so they cannot receive immediate treatment, immediate factor infusion. I think self infusion training is the only way where we can educate our patients to receive factor at the earliest sign of bleed, if not prophylaxis at least, so they can prevent disabilities. And also, Hemophilia Federation and chapters, no, they organize regular camps. Camps are very, very integral part of most of the chapters. That has got advantage. In hemophilia, the acceptance is very, very important. Most of the youths, they don't accept. They need proper counseling, and we make them to understand hemophilia, and automatically the quality of life improve by taking immediate treatment, as well as with proper physiotherapy, improving their joints and muscle, and thereby preventing the progression of the joint damage. I think these are some of the important things we need to take up and promote among the hemophilia families.
Thank you so much, sir. Thank you for your insights. And our next question is to Dr. Tulika. Ma'am, during the discussion, you mentioned that there is a lot of scope for international collaboration. While India is still, we are innovating, but there is a scope for collaboration. And given that currently we only have one approved non-factor product, are there any available products in the international markets that we could obtain, or are there any technologies that we could obtain to improve the provided to our patients?
So currently, there are clinical trials going on in India for two other non-factor products. One of them has been completed and has recently been published. The second one is still ongoing, and there are a few other non-factor products who will be starting clinical trials. So I would definitely encourage patients to volunteer for the clinical trials, because the clinical trials will give you access to the new non-factor products before they even come into the market. In a clinical trial, there is proper safety and guidelines being followed. Patients are encouraged to volunteer for the clinical trials, and
While we wait for Dr. Tulika, I kindly request Dr. Suresh and Dr. Ramnath to kindly give their closing remarks. So kindly unmute yourself.
On the
We can wait for Dr. Tulika to complete. I apologize. Dr. Tulika, you may go ahead and
I'm so
answer
sorry.
the question.
I've
That's
joined
all
from my
right.
phone, so every time somebody calls, it gets muted. So as I was saying that we have. Can you hear me?
Yes, ma'am, we can hear you. Dr.
Okay.
Suresh, can you please mute yourself so that
So as I said, this is a very exciting time for non-factor products. We have one approved. We have clinical trials for 2 other products already being done in India, and a few others will be starting soon. So I would encourage patients to volunteer for the clinical trials, and we are very hopeful that at least one, if not two, new non-factor products should soon be coming into the market. Definitely either next year or by the end of this year.
sure. Thank you so much, ma'am, for your insights. I now request Dr. Suresh to kindly give the closing remarks, followed by Tulika ma'am and Dr. Ramnath. So kindly unmute yourself.
on this auspicious day of World Hemophilia Day, I would like to emphasize on the role of government in making accessible, affordable healthcare treatment for these patients, number one. And also, I would like to emphasize on the need of the proper counseling and understanding of the disorder among the families. So I always tell that hemophilia is due to deficiency of clotting protein only, but not zeal or any skills in life. We should make them understand this and focus on their positivity and achieve in their life. That is one thing I would like to emphasize. And third thing is, yes, the the quality of life with physiotherapy, regular dental care, and periodical screening for inhibitors, and ultimately, at least annual health checkup has to come among the families of hemophilia to prevent further complications and lead quality full life. Thank you.
Thank you so much, sir. Dr. Tulika, maybe you have your closing remarks, ma'am.
So I think awareness is the key thing. Both in all people, there should be awareness. The patients should be aware about their treatment, the inheritance of the disease, and the doctors and the public need to be aware about hemophilia. That it is a severe disorder which needs urgent care, and these patients need to have access to good education. So I think with good awareness, we can really overcome this, and in the future, we have to be aware about our genetic family history, because now that we have controlled most of the communicable diseases, and even the non communicable diseases have very standard treatment protocols, it's going to be the genetic diseases which are going to be very important in the next coming era.
Thank you so much, ma'am. Dr. Ramnath, sir, you're not audible.
Uh, I would like to say that there should be a national program for all the rare disorders, including hemophilia, and there should be definitely more efforts should be put in screening of antenatal at antenatal period in the so that we identify and first only prevent this. The whole thing should the focus should be now on prevention and rather than treatment, which is difficult, and prophylaxis, especially with the non-factor products. And if once this program, if at all it launches, then I'm sure these products will be available. We should also have an indigenous manufacture of this, like Make in India and all that. In the coming few years, I wish that we have our own indigenous, production, and companies would invest in India and start manufacturing here, and that's how the prices will come down, and then it will be a boon for all the patients and their family.
Thank you so much, sir. Once again, on behalf of Voice of Healthcare, I thank all the panelists to share their valuable insights and sharing such new facets to hemophilia. And I would like to conclude today's session. Have an amazing rest of your day. Thank you.